It's the Houston version of Code Brigade for Code for America. Yeah, Code for America.
Something like that.
That's the
So do we need to click, or you will be clicking?
I can click for you.
Okay, perfect. Let's go ahead and. Hi guys.
This is it. This is in Houston.
Hello.
Normally it's called.
You. It's us here in the front. Well, thank you so much for coming tonight, and thank you for the invitation. This is my wonderful coworker, Betsy, and I'm Alex. So I just wanted to start by giving you an overview of who we are. We have found that many people in the community don't really know about us. They think we are NAMI, right? They think we are MHMRA. They call us different names. But here we are. So we have a brand new mission, which is all about solutions. So I think that this is a good match for you guys, because you are also all about solutions, right? And we need help. Some solutions we can invent, but other solutions we really need people like you to help us come up with the answers. And then our vision is a future of understanding and well-being for everybody. So we can go to the next one. We just wanted to tell you a little bit about our core programs. We have virtually 4 core programs. One is for veterans. We have a Veterans Behavioral Health Initiative. We work specifically with justice-involved veterans. These are veterans that struggled when they came back with all the stuff that they went through and the trauma, and then they became involved with the justice system. So the county has these really cool veterans treatment courts that they give these veterans a second chance. So we work with them. We also have a lot of education and outreach in the community. So we have a full program to provide trainings and mental health literacy presentations in the community. And then our central initiative is called Integrated Healthcare Initiative. When we talk about integrated care, is having settings where a multidisciplinary team of providers can take care of your physical and mental health in the same place as a team, as a multidisciplinary team. So that is basically what integrated healthcare means, and we have a full initiative for that. Mm-hmm.
Is MHA just in Houston, or is that like French?
No, that's the reason why we always emphasize Greater Houston, because there is a national office, and when you hear about MHA only, refers to the national office in DC, and then there are affiliates. We are the affiliate in Greater Houston. In Texas, another big one is in Dallas. There is also in Austin, and a few others.
Okay, and so for the Houston part, are the buckets of money equivalent to the size of the triangles? Or
No.
What is the level? What's the budget ordering for those buckets?
Well, our overall budget is $2.5 million. From that, about $700,000 is for the center, and Betsy will talk in a minute about the center. And then the next bucket of funding is for the Veterans Behavioral Health Initiative. Roughly every single program there, their budgets is about $400,000 to $500,000. The largest is the center, and right now it's a little bit less than $700,000. Yes, but overall it's about 2.5 million operation. We are considered small in the big scheme of nonprofits. So we will talk a little bit about why we need you, and the type of need that we need, because we are small, so we cannot afford a lot of technology. And then we have the center. You can go to the next.
The Center for School Behavioral Health, we actually did a project with the hackathon. I don't think anybody's here that worked on that. Do you know Meredith? Mm-hmm. Yeah. Around the work for the center. What?
Can I take your seat?
Oh yeah, absolutely. Yeah. Oh yeah. Sorry. Teeny. So the Center for School Behavioral Health. The work began in 2012 with MHA because, especially after funding cuts in the legislature in 2011 to education, there was massive funding cuts, and then essentially people were seeing a significant increase in mental health in schools because the first things to get cut are counseling and social workers, that kind of stuff. So in 2012, we started working with schools, and then last year the Center for School Behavioral Health was formalized, which, as Og said, is our largest funding bucket because the Houston Endowment is funding us for 3 years. So these are the 6 areas of our work. We have, MHA as a whole, we don't provide services. So we are not a mental health provider. So we don't have therapists, counselors, anything like that on staff. It's education, advocacy, collaboration. So we do a big part of all of our programs is connecting the different entities in Houston. So our collaborative connects agents, mental health providers, advocates with school districts to fill gaps where there's needs and services.
Does that mean you have no HIPAA requirements on any of your
Yeah,
systems?
we do, because we do not work on an individual level, like a patient level at all. So a big part of the center's work is that connecting school districts and agencies. So we work with, I think we're at now 26 school districts in the greater Houston area, so basically all the main ISDs and charter networks, as well as 80 organizations to try and fulfill certain recommendations to improve the systems level work with mental health in schools. The other elements in those are all the different program areas, but we do advocacy, so we do legislative work.
I can't read them.
Yeah, so we have a collaborative, we have the collaboratives, those meetings where we connect the districts and the agencies. We have learning communities, which are smaller opportunities for them to connect with one another. We do a lot of training, so especially like right now post-Harvey, we're doing tons of training with schools around trauma. And then we do stigma reduction work in education. Again, a lot of that's tied with the trainings. And then public policy advocacy, and we have an annual conference, which we just had this past month.
All our buckets of work have multiple components. We just wanted to abbreviate the whole presentation for you guys and get to the core questions. But yes, as Betsy said, pretty much what you see there for the center, give and take, all the core programs have different components, including advocacy, training, and working with a network of up to 200 partners. If you can go to the next one. So all our initiatives are growing exponentially. Last year, for example, our budget was less than $2 million, and now we are at 2.5, and we are about to unveil the new budget, and it may go to $3 million. But beyond the budget, really, that means that our programs are growing. And as Betsy said, all our programs are about collaboration. So if you click in the growth,
Just jump in, does that mean we're all getting sicker?
It means that
That's
people
a
are
good-
actually addressing it more.
that's a good point, and I
It
love
seems like
that.
we're going crazier in the last year, but
Because what we do actually concentrate on prevention. All our buckets of work concentrate on various levels of prevention. For example, a lot of what the center does concentrate on primary prevention. So not necessarily means that we are getting sicker, but like Betsy said, we are getting better in starting earlier. So a lot of what we do has to do with prevention, not only for happening in the first place, from behavioral health needs to happen in the first place, but also to treat them earlier so we can stop the demand for more services. And this is a point that we like to emphasize, you guys, because it's not only about more and more services. What we want is to stop the demand for more services, all kinds of services, healthcare services, which are very costly, of course. All clinical services cost a lot of money. And what we want is to stop that demand for more services. A lot of the funding that you see these days, they immediately go to healthcare services. And what we want to do is, let's see if we can do something to preclude people from going to a hospital, from needing a counselor, from needing therapy. There are many things that we are implementing in the community to try to sever that demand for more services. Yes, please.
Generally, like in just the last 5 to 7 years, there's actually been like legislation in Texas passed requiring educators to be trained in mental health and suicide. So now we're seeing requirements and mandates, which should exist, but whereas before there wasn't a demand for training like that because we weren't talking about it and there wasn't any kind of requirement for that in education programs.
So basically, these icons were supposed to open some links, but a lot of what we want to talk to you about has to do with the need to increase connectivity. Betsy mentioned that we do collective impact. All our bucket support, they have a network of partners. And what we do is that we work with them at various levels. But we need to increase the type of coordination that we can help provide to community services. Right now, as Betsy mentioned, due to Harvey, there is a plethora of services and funding being poured out into the community. And the little coordination that we were able to achieve, not only with the center, but also with the Integrated Healthcare Initiative and with the veterans, now is all over. Because everybody is doing something, because there is so much funding available that everybody wants to take the opportunity to provide more and more services in the community. So we are having a hard time trying to coordinate all these efforts, and we are not the only ones, of course, trying to do that. So a lot of the questions that we bring to you today have to do with the need to connect in a better way with our partners and with our beneficiaries.
So I'm going to talk a little bit. These questions are kind of specifically geared towards our youth work, obviously, because that's my focus area. But we have really focused this past year on our stigma reduction education initiative to try and get change the culture in schools to truly be focused on mental health. So if we go in and do a training at the beginning of the school year with teachers, that's great. But if it's the only time that mental health or trauma is talked about throughout the school year, it's not truly changing the way that students are being treated and needs are being met. And so our emotional backpack initiative is meant to try and infuse mental health programming throughout a school year and really change the way a school operates around mental health. So that kind of led to these questions, like how might we, one, bring accurate, up-to-date information and resources to not just our youth, but families as a whole. We do have like toolkits on our website for parents, for teachers, for students that have resources, but how can we make those more accessible and keep them current? The other piece is how can we reduce stigma around mental health and the fear of mental health issues, specifically in our young populations, because the reality is mental health, 50% of mental health issues start by age 14, 75% by age 24. So it is truly, mental health is an issue with our youth. So if we can get information to them and also help reduce that stigma, then we're increasing the chances that, one, they will get early identification, early treatment, and also prevent problems from worsening as time goes on.
When you could say 50% before the age of 14 and 75 before the age of 24, are you saying that's when they get diagnosed, or are you saying that when they talk to their psychiatrist, they
so that's when the onset, that is a great question. That's the onset, so when it begins. But the reality is, right now, the average time that it takes for someone to get diagnosed from the onset is 8 to 10 years. So if we're seeing kids of 10, 11 having a diagnosable or showing symptoms of an anxiety disorder, they're most likely not getting diagnosed till they're 18 or 20, which in that span of time, there's a good chance they have struggled in school, maybe not graduated, ended up in the judicial system, right? So it's a whole cycle, which is why a big part of the training piece is so that we can train the people, the teachers that are with these kids all the time, to be able to notice and see those things.
So I know for clinical depression, you have to have symptoms for a year before it's declared as clinical depression. But like people do get better from things like clinical depression when they're talking about these symptoms, because sometimes they have them flow. Like, are they separating these out into different kinds, or are they separating it out by like class?
That so that statistic specifically, as far as 50% by age 14,
Okay, probably.
or that's an overall.
That's an overall.
Yeah. So any instance of a mental health diagnosis, that's the overall 50% of those begin by age 14.
Do we have data on stuff like that, or do we not have that for the general population?
Like when they like in recovery periods and things like that. Is that what you mean?
Yeah.
Or as far as I know, we don't have. There is a major issue with the data that we have around mental health. there was even just recently a big report put out that's wonderful that has some really great information, but has data in it that we're like, wait, where's this data coming from? Because it is really, really hard to get accurate
Where is
data.
it from? Is it from the CDC or what?
Mainly, and that is one of the reasons why we are talking about data with you guys, because there is a major need. And as Betsy said, these are high-profile recent reports that are being issued that funders are paying a lot of money for. But when you start reading those reports and you go to the sources of the information that they are using, they are either national data and very old data.
And this is supposed to be a current study of our Houston community.
10-year-old data. But again, even mining data is very costly. When I met you at the Rice University launching of this big thing, I was hoping that they were going to start generating that empirical data, local data. But it turned out to be like a huge, very sophisticated hub for existing data that we know is already, by definition, old. So there is a huge need for current and local data.
So I know the CDC's data is telephone interviews. Is there a way to get local data from hospitals? If you can't get it like specific diagnosis for patients, that would be a HIPAA violation.
Yeah.
But can you get like, can I get from MD Anderson how many people they're serving from this demographic or that demographic? Can we get hospital specific information?
There is a lot of red tape on that. Right now, there is a huge statewide project to get clarity on maternal infant mortality, which apparently in Texas is one of the highest, amazingly enough. But
It is the highest.
yeah, but even to get data, right now we are just saying that it's the highest, but we don't really have data, recent data, because those projections were based on 5-year-old data. So we are just assuming that the condition worsened, I guess, but we really don't have data. And even the most reliable information that it can be accessed through payers, meaning the entities that are paying for hospital services, mainly Medicare and Medicaid and insurance companies. There is an almost by law, don't start me on that, but I heard in a meeting that it's almost by regulation that they delay the release of that information for years, 3 up to 5 years. So even the information that is available, they will not make it public immediately. There is a lapse of time that you have to wait to access that information.
Is any of it from like the Texas Children's Health Plan or Medicare and Medicaid? Is any of that actually public, like I could access it public? Or is it only public if the FBI asks for, files a report asking for it and goes through a bunch of paperwork?
And that is a question that we don't,
Yeah.
we cannot answer, but I can tell you that, for example, we are working as part of the Integrated Healthcare Initiative. We have a pending project with Texas Children, mainly through their plan, and we hope to get some access, immediate family access to hospitalization data, but because we are partnering with Texas Children Hospital. But there is a lot of intricacies involved in getting that information. Even aggregating data, because of course HIPAA regulation would not allow us to get individual level. Even with children.
Well, and that's a major problem with the youth side is that a lot of schools don't even track mental health referrals. They track behavior referrals, that kind of stuff, but they don't. A lot of schools don't track that they're actually students referred to the counselor for a mental health concern, and then if they're referred to an outside agency, there's no follow-up or tracking on whether they actually saw someone and got treatment. So that's
there's not school nurses.
there's a lot of schools that don't have nurses or have a nurse that comes like half a day every 2 or 3 weeks. Like in Houston Independent School District, there's more school resource officers, police officers than there are counselors, and nurses. I think probably don't quote me, but the majority of them do not have a full-time nurse.
Exactly.
It's shared.
And if you go to the next slide, the other set of questions, or one question really that we have for you, is linked to what Betsy just posted for the group, which is mainly about if we could create what we are calling right now a community knowledge management system, sort of like a portal that it could be used by multiple type of users, like people from the community, our own partners, this network of 200 plus program partners that we have, by funders. One of the things that we do in MHA is to help make those connections that Betsy was referring to. And those connections is not only between consumers or people in the community and service providers, or between service providers and service providers, but also with funders and service providers. If the links work, if you can click in any of those icons, if you go down the page, this is just okay, don't worry about it, let's go back to the, for some reason the links, we have links on everything. If you try the other icon. There is always something with technology, you guys.
It's probably my machine.
And this is the webpage of the Greater Houston Community Foundation. We recently had the opportunity to provide these type of services to them for a specific mental health project that they were meeting with some funders that were interested in investing more in mental health. So thanks to all the information that we have about our partners, we were able to provide that kind of information. But basically what we need is to improve our means to provide accurate and up-to-date information to people in the community, not only youth, like Betsy stated, but also parents and other people like us. When we need a helping hand, there are many resources in the community, and this may be, if you can go to the next slide, may be related to one of your projects. I know that Need Houston is something similar. We still don't know how that is going to operate, but these are some of the other things that are happening in the community. And one of the things that we wanted to bring to this organization is that before we even tackle a technical problem, we should do a survey of what is already available in the community and maybe learn from those. Because, for example, if you click on United Way, and let's see if it would open, but it would go to something that looks at this point very similar to Houston Need. I still don't know enough about Houston Need, but in principle, okay, that's us. Let's stay with us. You can just close all those. Probably the internet here is very slow or something. But for example, United Way of Greater Houston, and we are a United Way agency, they also have a means online to search for services. But I even tried, when I was doing research for a grant that we were writing, I needed some information for the East Corridor, that by the way is one East Corridor, East End, the port area and all that. And that is one of the areas in Houston that are what we call food deserts and medical deserts. Meaning in this great city, there are areas in Houston where you cannot find medical services. And we work with many of those ISDs, Galena,
Worse now.
Exactly. And it's worse now, you're right, sir, because of
The hurricane.
the hurricane.
East End is gone.
Exactly. The
All
East
positions are
Corridor,
gone.
all the east area of Harris County was hard hit by Harvey, and they already had the worst health indicators. And I mean third world country indicators.
That is where the
in Harris
lowest
County.
maternal mortality
Yes,
you were talking about earlier.
exactly.
That's where,
Exactly.
third
Exactly.
world.
So I was trying to find, okay, who else is there, right? Because we know a lot of what is going on in the community, but we don't know it all. And I tried the online service, and it was just like, I got really frustrated. Because it was like drop menus, and I believe that Houston Need also have drop menus. So I was trying to put myself in the shoes of someone in distress, or maybe like me with OCD, I haven't been diagnosed. I think I have. So imagine someone in you, a desperate parent looking information for a child, and you are faced with these drug menus, and you don't even know what kind of help
Yeah.
you need, right? So when we are talking about these needs that we still have, we are talking about something highly interactive that if I say help for my child, it would interpret it in a way that I can continue asking questions to the platform. And then maybe, okay, what kind of help? Maybe I can say,
They could guide you to the service that you need.
Right.
Asking it questions, giving
intuitive.
yes or no questions that could guide.
So
to-
you
Right,
already
right.
have, you've mentioned partners that you already have,
Mhm.
but I wanted to clarify on your partners. Does this range from social work to, like you said, children's hospital, physicians, and sort of everything in between? Those are the subset
To-
of partners that
yeah,
you have.
To
Exactly.
elected officials and their staffers. I mean, yeah, it is.
Public
I-
entities, ISDs, child serving organizations,
Yeah.
just Betsy's program has a network of almost 100 partners. And granted, many of those partners are duplicated with other areas of work in MHA. So because we work in collective impact, one of the other needs that we have is to be able to have a centralized something data information that all the partners can share. We do measure our collective work, but right now it's just like literally these people went out and do interviews with their partners to collect the information. There has to be a way to do it with technology.
Yeah, it's something that we have been working on, and the short answer is it's complicated. But just for the group, the 211 data that United Way has as a directory is actually managed by Texas Health and Human Services, the state agency, that then administers it through a statewide foundation called the One Star Foundation, that then contracts with local and regional data intermediaries, which are supposedly the guardians of this directory data, of which the United Way is our regional intermediary. And the
That
problem
didn't
is,
sound complicated at all.
Yeah.
and so there's software vendors that go in between them all. So there's a software vendor called iCarol that manages all that information. And there's a couple of problems. One is that the data standards between all these different places is different. So you lose things in translation. Two is that it's one way. So you have the state agency that updates it whenever the partner wants to update it. So maybe it was updated in 2014. Maybe Children at Risk's number hasn't changed since 2014, but you don't know. So it's a one-way data feed instead of it being two-way.
Right.
And then on top of that, and let me finish, Lester. On top of that, you have no particular standard to govern how that data would go back and forth. So what we're trying to do is two things. One is that we're trying to socialize the concept of open referral, which is a data standard that came out of Florida that works with iCarol, it works with all these groups. And two is developing use cases on top of it. So knowing the types of referrals that you would make in MHA, which is different than the types of referrals that we heard from, what was the group that we did?
Immigration.
Yeah.
services.
Immigration services that want photo ID flags, or the types of referrals that homeless services might have. So I just wanted to give you that context. And Need Hue is kind of morphing into kind of a layer on top of that open referral. So knowing the types of ways in which you want to refer and how you screen them. Let me ask you this: when you if you don't find what you need on the United Way website, do you Google or do you look at Yelp? How do you find other?
No,
Search
and I was citing data as an example. Of
Yeah.
course, we are not going to Google this for ourselves because we have this network already of partners. So, for example,
We
I
have
was
a
just-
guide that we give.
Well,
out.
yeah,
Most of
not
our
only
workers
that.
do. They'll Google it, or they'll look on Facebook, or they'll call their friend.
Yes, and all of the above. But what we are trying to get to is our agency need to create some sort of online portal that can be multifunctional, right? That if someone is looking for information about mental or behavioral health services in the community, a parent, a child can go into this portal, and it would be an entrance for youth, for example. It would be an entrance for parents. Who are you? And what are you looking for? That would be the entrance that the person would use. But if they are one of Betsy's ISD partners, then there would be an entrance for an ISD to enter into the portal and share data, information, access online trainings or information about trainings that they have already taken in person, for example. So that is what we mean by a multifunctional portal. That right now, for the lack of a better term, we are calling it a community knowledge management system. Now, it would be really neat if someone could create an algorithm that could utilize the information that is already there in the various portals, like what you guys are trying to do with the City of Houston, like the United Way information, and many others that, and we will send you this via email probably, and you will hopefully will be able to open all those links, because there is a plethora of different type of directories out there already in place. Some are more sophisticated than others, but at the end of the day, none of them are accurate, up to date, or fully user friendly. This is pretty much what we need. We also dream about having some sort of online trainings for our partners, or at least some sort of refresher offering that after they take Betsy's trainings, they can go online and get additional information, articles, right? Things of that nature to support the learning or the training that they receive through Betsy. So this is our dream. Now, the key is not necessarily the technology, because we could purchase these from Salesforce, for example. They can do everything and anything for a price. And we already tried that route. So we are a small organization, $2.5 million operation. So we don't have unlimited resources. So one of the challenges that we are posting to you guys is low-cost technology and highly functional technology that we can maintain in the long run.
Yeah, so the maintenance piece is a big part of it. Like even with our hackathon group, we talk a lot about gamifying mental health information and statistics for youth to make them want to access this and recognize how common these things are. But yeah, one of the ongoing issues is then a year from now, when maybe that statistic's different or whatever, like no one at our office has the understanding or ability to fix something like that, you know? So yeah.
Yeah, so my recommendation to that would be, because this community knowledge management system has so many pieces to it, I would say we pick one piece, we prototype that piece out. Maybe training is a good one, because you're already doing that, and figuring out a really good way of delivering training, tracking training to see what partners are watching it, how they're watching it, and then using that data to go get a grant so that you can hire a company to build this for you. Because what I will say is that while kind of free volunteer labor is really good for prototyping, it's also not good for maintenance. Where you can get a really good idea of what your requirements will be through this kind of like experimenting with the community, and then be able to raise money pretty easily to build it.
Not
So-
pretty easy, I can tell you that,
Yeah.
because I'm in charge of that.
I
And it's
understand.
pretty tough to raise funding for technology. But also our consultation to you guys is that if you are aware of low-cost technology, especially as Betsy says, for maintenance purposes, because they say we can get a grant to get the project started. And we already have some seed funding for a project that we are working on. It's about $30,000, but then it's the maintenance. And trust me, for example, with Salesforce, that is the well-known provider, they give services to the government, for example. They can do anything, all this, but it's very costly. So if that is the only route, then we will have to, I guess, go back to our wish list and scratch 90% of the wish list and just go back to the basics.
Well, maybe I wasn't saying that we should throw things out. I was more saying let's break it up and put it in order and then really focus in on the first piece, get data around it and analytics around it so that we know how it was used and how it's moving the needle. Like if you're delivering partner trainings virtually and it's 3 times more effective and like 10 times more partners are using it and we have the data to back that up, then I think it makes a strong case to expand into that next module and the next module. Because I think that everything that you're saying personally, I'm like, yeah, I want to work on this. Yeah, I want to do this. But then I'm like, okay, where
Where
do
do
you
you begin?
start? Yeah. And to your point, like using low-cost technologies, using off-the-shelf technologies, using things that you can just deploy and then get data back to see what the impact is, I think is just food for those grant applications.
Yeah.
I'm still hungry. That's why I only had 3 pieces of pizza.
Oh, definitely.
And I mean, and there are so many different needs in this area that this, like, there's this one thing, but there's 50 million other things that apps and whatever that could be created that would be better than what we have now. Yeah, I mean, we're so behind in this area when it comes to data technology, how we're meeting the needs of the younger people that want it this way, and it's
Right. So how about this one? Would that be small enough to tackle it?
Yeah, I mean, I think these are great project prompts. I actually was taking notes and I posted it to our GitHub, and those 2 bullet points I actually put out there because they're broad enough that you can really think creatively around it, but they're specific enough to say like this is the goal in which we're trying to accomplish. Yeah, I think those are great.
in that hackathon group, this is basically what they worked on, and we met afterwards, but we haven't been in touch since then. So, but they did have a starting idea of what to do with here as well.
So, may I ask,
I think it was from May.
what
Yeah,
have,
from the May one, it was
what have you tried in the past that just so we don't go in that direction?
Well, in the past, nothing like this. Our technology is very rudimentary. We are just now preparing to migrate to our first program database. Sorry to say, that is how poor we are. And yes, grants are wonderful, but when you have to apply for grants for our bottom line, then you have to make those decisions about whether to pay my wonderful Betsy here or to get a sophisticated portal. So of course I prefer Betsy than the sophisticated portal. So give and take. It's not that there are no grants there, yes, but we will also need consultation from you guys who are the experts, because we would not even know how to price it. This is something that we try to do for a very basic database. So we did some research over a year ago, and then that is how we knew from Salesforce I can do anything and everything to others that are just basically templates and do it yourself.
Yeah, the first call I had with a friend of mine that works for Google, and I was like, okay, so we're thinking about an app. Like, what would this look like? I don't even know where to begin. He's like, yeah, tell me what you want. I'm like explaining. He's like, yeah, that's totally doable. Like, I really think you get this done with like $100,000. And I was like, I think you missed the first part where I said we're a nonprofit and have no money.
Yeah.
The first bullet point, you have already started collecting information and resources for youth and families.
So
you have.
Yes, we have like a youth resource guide already in existence. We just went through a round of updates, a first update in several years this past summer, that is free and low cost services in the area. It's definitely could be expanded, and there is a lot to be added to it. But it is there's 100 agencies and providers probably in there that it's a good start of a database.
So one thing to your question about maintenance is having a leader that is the advocate for maintaining that information. Because if we can make it easy to maintain, it doesn't matter if you don't have somebody that's
willing to take
collect and do that information. That's something that across the board, mental health, it doesn't matter. If you don't have someone that can maintain that information, so
Yeah,
that
absolutely.
would be you.
No,
actually,
probably not. But yeah.
When we were talking about maintenance, we were mainly thinking about the technology piece maintenance. Because, for example, right now, maybe I can mention Cognito's name, I already did. They are trying to work with us to get grants so they can update their highly sophisticated online trainings. They use avatars and that kind of sophisticated Cognito with a K, Cognito. And we work with them, the center works with them, but even then, they are having a hard time to get enough money to update their technology. They want to update their avatars, for example. So it's, yeah, $100,000 will not do it, let's put it that way. So when we talk about maintenance, we are talking about mainly the technology piece of whatever we can implement. But we don't even know how much would it cost to maintain any of these pieces.
$100,000.
If we are going to
It
break
might,
it down.
what's cool about, and maybe one way of framing this, and how to work with the community on this is that, when you get a proposal from Cognito, they're selling you their service, they're telling you what it costs for them, and they have their kind of way of doing something. And let's say you needed to do something slightly different. Well, they have to kind of take it all apart and rebuild it, whereas, if somebody was starting from scratch, it might be really simple. It's like, well, it seems so easy. Why don't you just do it this way? But they have to decouple this and put it all back together. So I think one way of engaging this community is it's a blank slate. Like we can use whatever tools we want. If we just want to prototype something with YouTube and a website, like we can do that. And that removes the barrier of execution. It's like you don't have to spend $100,000 just to execute. Now to build that out and to maintain it, I don't know I know what things cost specifically, but I don't know in general like what it would cost to maintain any of these projects. But certainly once you have something out there in the wild that's getting used, it makes a stronger case to continue investing in it. So I think that we can certainly help with like ideating and coming up with prototypes and drafts of projects, and even things that can survive in the wild with regular use. Yeah. Well, as soon as you get people start using things, everything changes. You put it out there, and then a whole slew of changes come in, and that's why having a budget and having a vendor on call, or a developer or an independent contractor that you hired to help you with that in a paid capacity is really helpful, because it's their job to make it work. But that doesn't necessarily need to cost $100,000. That could cost a few $1,000s potentially, depending on what it is. So I think we can certainly help kind of sketch out those ideas, prototype them, and help figure out like what directions you want to go in as you start to build this community knowledge management system. Yes, it's community with a C.
Not the K that you're trying to do with. Yeah.
Yeah. So I hope that's helpful, because I think a lot of the volunteers are going to want to work on something for a set amount of time, not like 2 years. But they might work 4 weekends on something and build something really cool. What else, as I'm taking notes here and putting it online, what other things would you want to see, or what other components to that knowledge management system would you envision?
So if you go back, we want to emphasize forward. I'm sorry. We want to emphasize the need for data. So, for example, from this piece that we are calling it multifunctional, the example that we use, the information that Betsy and her team is collecting on an ongoing basis from ISDs, and this is not impact-related information, but just to know from our common agenda what recommendations they are implementing, what kind of efforts they are implementing in the community, and then Betsy and her team has to be collecting that information. So that is one of the functionalities that we are dreaming about for this portal or management system, that our partners could log in and share that information automatically, would be the word of the concept. So Betsy doesn't have to go in person and do these lengthy interviews to collect the data, for example.
Still have to email them 40 times. Still have to get on and do it.
You please log in.
A robot can.
We can automate that.
Right. Sharing of information. For example, right now you have heard the Greater Houston Community Foundation is managing the Harvey Fund. They collected almost $100 million. From that, they have been dispersing a lot of millions into the community. But one of the requirements is for every applicant to have their needs assessment. So we have a lot of information here and there, but it would be wonderful if this management system could have the functionality also for our partners and all these entities to share information. So not only MHA can apply for grants, but also our partners will have local data, information that they can use as needs assessment to apply for funding, and also, most importantly perhaps, to inform their own decision-making process. So that is another functionality that we would love to have. And then the resources piece, that we also have another directory for the community in general, but it's a piece of paper, to be honest, and you can download it from
I linked to it. I linked to it on the GitHub.
Yes, sir.
Just in case you're curious.
Is a needs assessment something that requires a human talking to the applicant, or is this something that's done on forms and online?
It can be either. There's currently a needs assessment happening that's about 2 years in, 1 year in, with the Baker Institute at Rice, where they're doing a needs assessment of communities and in the schools, what communities need for their schools. And so they're actually doing in-person ones where they're getting like a parent at the school to take charge and get other parents to do that. But it is
I think of needs assessment as for a person.
Oh,
An
no, thank
individual.
you for that question,
But
yes.
you're trying
exactly.
needs assessment of
A
For the community, a
Yeah.
community
Oh,
needs
I see.
assessment,
Yeah.
thank you for clarifying that, yes,
Okay.
it's a community needs assessment, so it would be our other partners in the community, other entities, public, private, nonprofits, sharing that information. So we would have like a hub of current, real-time information, what happened, even if it's last year, that would be awesome. Because as I mentioned at the beginning, all information available is easily 5 and even 10 years old. And that is what it's been used in current reports.
Okay, so there is a lot of money, there are a lot of Harvey
Mhm.
affected people.
Mhm.
Is there some uniform needs assessment for the individual?
No.
We actually
Not
just
even
had
the state
this
has that.
conversation in the meeting yesterday about how there is not accurate data out there, pretty much anywhere, even about what happened to Harvey. Like the maps that people are being shown for the large scale that are out there were based on like predictor data, like not
Models,
actual
models.
models. They were not actual numbers, and so even with just the flood maps, they're wrong.
Mhm.
And there's a lot of different entities trying to do those assessments, and they're still all happening independently.
But
Right.
yeah, they don't have a uniform
Nope.
data model.
No.
shared.
Now,
Which is a problem, right? I mean, that's a major problem.
Us, thanks to this network, and there was a map in one of those links, and my beautiful Betsy helped me to put together. Thanks to our network of partners, we were able to verify the information. For example, those models show the east end of Harris County as one of the areas that were affected the most. So by talking to our partners, Galena Park ICs, other clinics in that area, we were able to confirm that in fact, yes, they were overwhelmed with the need. So that is like a second layer of information that we can tap into thanks to our network of partners. So, and we did due diligence because we had 2 big grants, one from UNICEF and another one from Kaiser Permanente related to Harvey. So we needed to make decisions about where to concentrate efforts. And of course, probably you also know that there is a lot of services in the central area of Houston. So one of the things that we did for the Kaiser Permanente grant was to concentrate on the north side of Houston with some of the programming, and now with the other part of the programming, we are concentrated on the East Corridor, which are the areas that have less services and greater need.
What is the East Corridor? What's the fund
The
of
east the east part of Harris County. all the east. The
When
core-
you say quarter, is it east, west, or
corridor
north,
is
south?
from,
Corridor,
is from
yeah.
yes, it's from yes,
East,
north
west.
north to south.
Oh, it's
yes.
north to south. of
I mean,
Florida.
Yes, it's
What
from
I'm
the
saying, north to south, yes, because it's east. North,
On the east
north-
side of north
Harris
to south
County.
corner.
So
Yes,
like
okay.
the belt between like 610 Beltway, that area, Beltway, east
Mhm.
side of
Between-
Beltway, around there.
yes.
610 and the Beltway.
So like LaPorte, Channelview, Galena Park,
Yes, all the way.
yeah,
to-
Ship Channel. I mean, essentially.
Yes, yes. But from north to south. All that is what we call the corridor.
The ship channel corridor.
Yes. Yeah.
So I think you both bring up a really good point that there isn't a clear model for how to smash together all these data sets to understand what happened with Harvey. I think that there's a reason for that because a lot of the data that is the best data is FEMA data and that is heavily controlled and regulated.
Yeah.
Mhm.
But there is, I mean, we do have a general idea of what happened and how many structures were affected and how much damage it caused. But I think that from a services standpoint, something that I've been working part-time on a project with this, something that was an unexpected roadblock was the ability to analyze service referral data from 211. And I think that you all occupy a really unique position to be able to say, hey, we want to analyze service referral data. We
Exactly.
want access to this data. Can you share it in our consortium? Can you, or if you're not part of a consortium, if there is one already, you should be part of it,
Right.
just so that you can get a better sense of how those referrals worked during and
Exactly.
post-Harvey. Because I see the same thing on damage and debris, where trying to get a full damage assessment of what happened is a combination of 7 different data sets,
Uh-huh.
where there's a lot overlapping, and it takes time to
Curate
get it
the
all out. But you all have the ability to advocate and pressure the One Star Foundation and United Way
Mhm.
to do a bad phrase, but a controlled release of this data to you all. So anyway, that's my two
Yeah.
cents.
For example.
I think you should hit them
yes.
over the head with the data, or the data requests.
Yeah.
For example, yes, no, absolutely. Especially because all our areas of work, what we are trying to do is to increase coordination of services, which is part of the integrated care model.
So, Mental Health America is in lots of cities,
Yes, we are mental
But-
health medical ready Houston.
but every city has to make a knowledge management system like yours designed.
And we are completely independent. So like nothing we do is like mandated or comes
I
down
understand
from
not mandated.
Mental Health America. So
You all
our
have
everything we do is completely independent. Our own program, our own work.
I got that.
And even
But
more-
You all don't even talk to each other? or-
Yes, of course, yes, especially as Betsy said at the beginning, we do a lot of advocacy work, and a lot of coordination happens related to advocacy work, because as you can imagine, there is a lot of advocacy in DC, and that is led by our national office. So we are affiliates, right? But every MHA in the United States is a different entity, but also, more importantly perhaps, every MHA has a different array of services. And we are almost one of the few that doesn't provide clinical services. So we do provide services, but as Betsy mentioned, we don't provide direct clinical services. We provide other type of services.
But for example, every MHA needs a community knowledge manager.
You would say yes, every
Okay,
MHA
and we
will
all-
need that.
you-
But
Yes.
also for many MHAs, this isn't their role.
Mhm.
Our role in the community is connecting services, is bringing information together, is connecting providers and funders and all that. A lot of MHAs, that is not their
Just
role in the
clinical
community, so they wouldn't
services.
necessarily, this wouldn't necessarily be beneficial to them because they may just be providing
Right.
therapy and that's it, so this wouldn't be their realm. Does that make sense?
Yeah. For us, it's such a
I understand it doesn't make any sense.
No, but yes, no, you are correct. They can use something like this. For us, it's such a need because everything that we do is collective impact. So by definition, our medium of work involves our partnerships with other organizations. So this is a vital piece for us. It's a great need for us because that is our medium, that is part of our methodology.
And every city definitely needs one, but
Right,
yeah,
right.
yeah.
Mhm.
Well, perhaps if we do go for here, then you could market together, make sure you can.
Of course, I thought that is what he was leading into, yes.
No, it's
yes.
some time.
Yes. And we do that, yes.
What is the need you and community knowledge management system that they need? Those sound similar. Am I not understanding?
Well, NEQ is a prototype that looked at how do you arrange 211 data in a way that you can then build applications on top of it. And I think they built a text bot and they built a couple of other little front end pieces to it. But NEQ was really Nearish and company wrapping their heads around the data structure. And then during Hardy, we got connected to the folks from Open Referral, who have really thought it through a whole lot more and have already had pilot programs in different places and worked with the software vendor and kind of educated us to the back end of how all that works. And so NEQ has really kind of become this front end testing ground for different use cases. So for y'all, you have use cases around mental health, but we came from a meeting earlier today of use cases around undocumented communities, which might be mental health, but it has that cross
Maybe legal
sector of,
services.
yeah, I need mental health services, but I also I don't have a photo ID, that kind of thing.
Yeah, but that slide doesn't actually mention mental health. That's a generalized community knowledge management system, which I guess is
Right.
the general case of need you.
And
Right,
thank
I
you
mean-
for making that point, because we didn't want us to go a lot into the theory of what we do, but there is something called the social and community determinants of health. So for us, we use the term of the social and community determinants of mental health. So when we talk about mental health, there are social, economic, and community conditions that affect the mental health of individuals in the community. So we are here not talking about only psychiatric or clinical services, we are also talking about social health and human services. Yes, ma'am.
You mentioned you were looking into integrated healthcare systems, and you also mentioned you're working with veterans. Are you working with the VA, and can you expand on what you're doing with veterans and any data you're using?
Yes, I can expand on what we do with veterans, but not so much about the VA. For example, when you guys started talking about HIPAA regulations and those kind of things, immediately I thought about our veterans program, because even though we are part of the jail diversion teams, and we are embedded with the veterans treatment courts in Harris County and also Fort Bend, there is a limitation of the information that we can receive from VA. Even more, is this being recorded? Even more, there is also a limitation of the information that we can ask from our participants and information that we can collect due to VA regulations. So, of course, we are different entities and we could say, I don't ask these questions, but we are part of a team, right? So we have to work with the VA. The VA is wonderful. There are a lot of technological advances that has happened because of the VA, surely. There are a lot of issues as well to access convenient services, but give and take, right? Give and take. So we opt to have a good relationship with them. So we try to work with whatever information we can collect from our participants.
What exactly are you offering these hospitals that you're pairing with? Are you mainly consulting with them? Are you offering patients resources? What exactly are you providing?
Right. So integrated care is the gold standard in healthcare. You would think that for Betsy is an educator and a social worker, that for us to work together to help a family, it would be no-brainer. But in reality, the way that the medical professionals have been trained is to stand-alone services. They don't work very well by definition with other providers, such as psychologists, not even nurses. So this is, even though it has been around for a couple of decades, this is still brand new in the community. And the work is almost one provider at a time. So you answered pretty much the question in reality. A lot of what we do is consultations for entire clinics or teams within those systems that want to start implementing integrated care. Now, I can send you also the model of integrated care, which goes through 6 levels, right? So some hospitals and clinics are at the basic level of co-location, it's called, right? And then they go to collaboration, and then cooperation, and then fully integrating all the services into one. There are beautiful examples, even local, of cases that, let's say I'm the doctor and Betsy is the psychologist, and we are in the same consultory, talking to the same patient at the same time, and we are consulting on the best way to treat the patient. So that is fully integration of services. But it's a process. So a lot of what we do in that area of work is consultations, trainings, even what we call launch and learn options, and patient education, because this is another thing. Many people, patients, people in the community don't know that these services are supposed to be provided. Even in our cases, right, and we are supposed to be highly educated people, we have to really sometimes advocate for ourselves and ask for second opinions or ask questions why you think this is what we should do to treat my condition, so on and so forth. So a lot of people in the community are not that sophisticated, period. So we also provide trainings in the community, what we call mental health literacy, just like any other type of literacy, to educate patients to access and request integrated services. So it's like Betsy was explaining for the center, pretty much the same thing happened with our other areas of work. It's a thoughtful array of services that we provide to help people in the community, but also providers, to make sure that they are implementing best practices.
And there's also a piece as far as the integrated care of actually working with the insurance companies to make sure that the mental health services are paid for in the whole payer system. So has been a big component as well, as making sure those systems are in place so that the mental health services can be provided in an integrated way and be paid for.
When you're designing these programs, have y'all been the ones doing the primary research, or are you finding like articles and doing secondary research, like reviews and such from JAMA and such?
Both, because we started this particular area of work, we started it in partnership with the Heart Foundation for Mental Health, and they were like the institution in Texas doing direct research on those issues. So a lot of the work that we are doing, or we started doing for the last 10 years, came directly as a result of our working relationship with the Heart Foundation for Mental Health.
And it's our collaboratives, like what every department program has its own kind of collaborative with all these partnerships. And so like the Integrated Care Initiative has their own collaborative that published a report 6 months ago, like a 100-page report or something like that. It was all put together by all of these different entities coming together of the collaborative.
What's the name of this report?
The what?
I don't even know the title.
Making Together Work, and it's in our webpage, but I can include that in our notes to Meredith, and she can forward it to all of you guys. Because basically, again, everything that we do is collective impact. And it's a beautiful model, actually. We spent a year long of community consultation to also continue answering your question, consulting with consumers, which are the individuals in the community using this type of services, consultation with our partners, stakeholders that we call them, and then we come together as a group to define the common agenda. From everything that we think needs to happen in the community, then that group decides, okay, these are the ones that we are going to prioritize, or these are the ones that are feasible. Like here my friend is doing, okay, from all these things, maybe we can start with this. So that is the process that we use to start all our areas of work. It's virtually a year long of community consultation. Probably some of you are familiar with appreciative inquiry. So this is pretty much what we do, just doing inquiry in the community directly with our stakeholders. And then we built that common agenda and we started working on that.
You call that appreciative inquiry?
Appreciative inquiry. Which
that a
is-
term in the field?
It's the US version because actually that started many years ago in Brazil with Paulo Freire.
Mhm.
Yes, sir.
So, in your collaborative, how collaborative data-wise is it? Are people territorial about the data that they have, or at least within the collaborative, are they more willing to
It
share
probably
some of the
depends.
data?
I would say it probably depends on the group. One, it also probably depends on the data. But like for example, we have a learning community that's a subset, the School Behavioral Health Collaborative, that's just for agencies, agencies and providers. And one of their like main goals is to come together to share grant and funding opportunities where they can create partnership applications so that they are no longer competing, but actually building community-based programs. And so I think there is. I think in at least the school side of it, with our partners, everybody is feeling the need of like we cannot continue to operate in our silos because we're overlapping. We are not having the impact that we could if we came together and we're able to. What's the word I'm looking for? But work together so that we're not having 5 programs in one school that are essentially all doing the same thing when we could be doing 20 other schools. Duplication. And so I think that for the most part, we see within our school district learning community or collaborative with the schools and agencies that there is a desire to share the data, but there's not the means there to do so.
That is not labor intensive because our liaisons, they are very busy people.
Yeah.
And they are that kind of people that they want always to do more and more. So there is a limit to what they can do. And then there is yet another survey that they have to do.
Well, that's another area where volunteer labor can help. If, to David's point, if people aren't territorial because they don't want to give up the data, they're just, overstaffed or understaffed, they don't have the bandwidth to get you this data.
Yeah.
That's something that we can all help with. If somebody needs, SQL queries written just to generate a report, like we can volunteer and help with those things just so that y'all can start sharing data.
Yeah.
For what it's worth, just to.
Yeah, because I think that is a huge need, and it is, I think, time more than anything. Like I said, with a lot of schools, they don't even track mental health referrals formally. So if we have some relationships where we're providing training, and so they have a deal that they're going to give us this information, that's super labor and time intensive for that school counselor or social worker, whoever it is, to manually put together all of this stuff. So yeah.
How are they storing the data? Like, where does it exist now?
Because we work with 200 partners, everybody stored their data in different ways.
There's no
So
centralized.
what we
Are
do
they at least digital?
exactly what we do is surveys, and we just started doing digital surveys because before it was paper.
I don't think
so-
to answer your question, I don't think all of this is digital. I mean, yeah.
There's still
But
a
it's
lot.
basically, because everybody has their own system, then it has to be via surveys. And they still have to pull information from their own systems, and then put it in our surveys. Now, there are plugins, I know. At least I know that much. But they will cost money, and that would be a zoning issue. There are many of these things like ISDs, they are humongous systems. They are not going to allow the plugin to be into the databases and things like that. So they are willing to share some level of information, but they will not be willing to do something as invasive as streaming or making systems to work together. I don't think so.
But they do already share a lot of that data with the Kinder Institute and
Yeah, that's a-
Education Resource
Right.
Collaborative,
Yeah.
which could be a really good ask if the ISDs gave you permission to access that subset of the data to share.
And we actually have Dr. Turley, right? She's the one in charge of she has one of her fellows or whatever they are. We met with her when she got here and right after Harvey, and her primary interest is in mental health, and so that is one thing she is going to be working on this year is looking how they can take the existing data that they already have and either what new additional data that they need to start gathering from schools, or how they can manipulate what they do have to find out a lot more about what the mental health needs are. So that's something we're hoping to see by the end of the school year. So we'll
Very
see.
cool.
Yeah.
Yeah.
Because that would be huge. I mean, and they are expanding into other districts, right? I believe that they are.
For her?
Yeah.
I'm
Right.
sure they are, yeah.
So that would be great. Yeah. Because currently, I don't think that they haven't collected to this point anything specifically about like mental health referrals, but there's a lot of conclusions you can draw to a certain extent based on attendance data and
Sure.
all that
Disciplinary
stuff. So,
actions.
I think a big concern too that we just recently talked about this week in our office is how now, if we've had these certain ways that we're looking data like attendance grades that we look at and think that we can pull from, but now with Harvey that changes everything. We have a couple of different projects where we're supposed to be comparing last year's school data to this year's to look at effectiveness, and that's irrelevant now. So I think that's going to be an issue we see going forward too. Is how you
Yeah, the
look at
data.
that and compare year to year when everything has changed now,
Kids are getting 3 full meals too.
which is
That's
huge.
it.
No,
Which is
absolutely.
Wonderful.
Yeah. But when you have a kid that maybe missed 4 days of school last year that's now missed 30, that's you can't really compare that. So, yeah.
Awesome. Does anybody have any other questions? Thank you so much
Thank you,
for
guys.
giving us
Thank you,
this
guys.
brain dump. It was amazing. I feel like all of our light bulbs are going off.
I
This
hope
is
so.
Fantastic. Yeah.
It's good for we need this in our community.
So do you think that the community knowledge management system will be ready by next week?
But what I do think we can do, and what we should do, is in our Slack have a conversation about how we can break it up into components and start working on the first component. So maybe a good next step that we could have with you is to think about of all the different components that we outlined, the partner training, the resources directory, all this, where should we start? And I just want to give you a round of applause for standing up there for an hour. Such great information.